And so over here, oh, there you go. So got it. Hold on. So over here, you have what's called a sensory station. Over here, you have the neurosensory integrator. Right. And then, we have different balls and hula hoops and glasses that strobe and all that stuff. Here's a little table with some rehab. If you look at our rehab, we've got gamma core, vagal nerve stim, peripheral nerve stims. We've got Prologel. We've got dynamic tape. We've got headbands that are weighted. We've got weighted vests. We've got all types of the hypervibe type tools. We've got ARP wave. We've got power breathe for breathing. We've got rebuilder. We've got V lights. We've got TENS units. We've got different vibration tools for, mastoid vibration. We've got tons of glasses and more colored glasses and hemistim glasses and all types of glasses. And here's our gym with some dumbbells, a treadmill, like an iron neck, different bike, stationary bike. Finally, last few rooms. Room 3 is kind of our passive room where people could kind of come and relax. In room 3 is where you see some V lights, you see some in lights, you see a beamer, you see some oxygen, and that's kind of what people get in this room. This room is a tilt table. And so this room, you have a tilt table, we have an SSEP. Here is our eye movement room, an interactive metronome. Here is the Burtech room where we do balance testing and we do balance rehab. This is our VNG room where we do eye testing. And finally, I got 2 rooms of exams. And so this is one of our exam rooms where we have everything you need for an examination, right? In the room, a TV, etc. So that's the clinic. Do you need this big of a clinic to do functional neurology? Definitely not. But that's what we decided. It's nice to have. And we've got, I think, 8 or 9 diplomats right now that work for us. And we have about 30 employees total. And so we've got a pretty solid operation. And the reason we have a pretty solid operation is we help people. That's it. We don't overmarket. We don't spend a lot of money on marketing. You don't see us promoting ourselves all over the place. Our clinicians are busy just helping people and getting people better. I see this Dr. Cassandra on here. She worked for us for a little bit in Illinois. I thought she'd come to Florida with me. Unfortunately, it didn't work out that way, but we love her. And, and she's great and a great resource for you. And she'll tell you, any questions about our clinic. She will tell you what's going on. If you mute yourself after asking a question, I can mute myself on a computer. Okay, I like it. So that's the clinic. Today, we could talk about whatever you want. I was asked to talk about kind of muscle testing and brain and neurology and vision therapy. So that's what I'm planning on doing. What I'm going to do is I'm going to mute myself right now, and you could ask me any questions about clinic, about, I can go through patients, I can go through business, or I can jump right into the lecture. So I'm going to mute myself, and you could tell me what you want.
All right, guys. Any questions? Or should we start with the lecture?
Okay, so Dr. Traster doesn't actually have to mute himself. I'll just
Right. Any questions, anybody?
Can you run down how is day 1, day 2 look, or does he do a day 1 and day 2 in the same day? Like how does that exam, and then how he presents that care plan?
Like how an initial patient visit works?
Yeah,
okay. Did you hear that, or do you want me to repeat it? I can hear you. Unmute yourself. It's okay.
If you can you repeat it? Because I could hear you the best.
So the question is if you could run the students through an initial patient visit and how you would day 1, day 2, like when you have your exam, when you do your report of findings, initial treatment, if you all do that in 1 day or 2 days, how that works,
So let's go what's my schedule like today? Let's go to my first patient today. And I'll go through what it looks like. So give me 1 second. So first things first, as I pull this up, every patient that comes into our clinic gets more or less the same examination. So what does that mean? It's a 3-hour evaluation. You're going to get a QEEG done. You're going to get a neurocognitive test done. You know, we use C3 Logics, but there's other good ones out there. They all kind of use similar neurocognitive testing. We do a full VNG test. Our VNG, what we do in our clinic, and we always modify it, you know, we're always trying to do things better, is our VNG is we start with eyes open and dark and relax your eyes. We then test eyes open, head right, head left, right lateral flexion, left lateral flexion, flexion, extension, all eyes dark or eyes open in the dark. We then do in the dark about 15 degrees, gaze holding right, left, and up. Some doctors do up and diagonals. You know, every doctor has some flexibility. We then take the goggles off or the cover off. We do a gaze holding test. We do a horizontal and vertical pursuit test. We do horizontal vertical saccade testing. We do optokinetic testing, horizontal and vertical. We then go and do a balance test, foam on a flat surface, eyes open, eyes closed, on a foam surface, eyes open, eyes closed. And then we do eyes closed, head right, head left, head forward, head back. And then we do dual tasks where you're doing every other letter with your eyes closed. And that's pretty much our balance assessment. And then you get a full evaluation, you know, and we'll go through quickly pretty much our evaluation. And then we do a report of findings. And so in about 3 hours, you get your diagnostics done, you get your evaluation done, you review their diagnostics and the exam with the patient, and you give them your kind of report of findings and your advice of treatment, you know, so that's day one. And then from there, they schedule, you know how they schedule local patients, a lot of times schedule once a day, you know, for the first 12 sessions, or at least three to 5 times a week. We try to do at least 3 times a week, but a lot of patients do 4 or 5 times a week. But then we've got intensives, you know, I don't market intensives at all, but because of the way things have happened, you know, I see a lot of people that fly in. And so we do a lot of intensives where they come in 3 times a day for a week or 2. Mostly it's a week, but some people choose to come for 2 weeks, you know, especially if they're from Australia, because I used to teach in Australia. I see a lot of athletes and pro athletes from Australia. And so a lot of times that flight, they'll come for 2 weeks. So that's pretty much the intake process. Our therapies are about an hour long. When you look at our evaluation, I'll go through our evaluation real quick. So let's just go through a case study. How's that? And then you guys can ask me anything about the case, and I'll just pull up his case. So the guy came in, he was a 20, and by the way, I'm throwing this out there. COVID's changed things a little bit. I used to do this, like, and some of you guys might be a part of it. There used to be a forum called like maybe the Student Neurology Alliance or something like that on Facebook. And we used to do, like, you know, every once in a while case studies and Zoom where people from all different schools across the country meet up. I'm happy to do that again at some point if you guys want me to. I'm super busy, so I'm not the one that's going to offer it. Like, again, I have no ulterior motive, so it doesn't necessarily benefit me to do it other than I'm happy helping other people. So if you guys want me to start doing that again for you guys or for other students, let me know, and I'm happy to make that work. And it was just like an hour every week or 2 of just going through cases like we're about to go through real quick. And so 24-year-old right-handed male whose chief complaint is brain fog, fatigue, irritability, anxiety, and nausea. Right? So right off the bat, you look at that and you say brain fog, that could be a lot of things. Fatigue, that could be a lot of things. Irritability, that could be a lot of things. Anxiety, that could be a lot of things. Nausea, that could probably be even more things, right? And so right away, you look at this, and these are non-specific symptoms that don't really relate to a system in the body or an area of the brain, right? And so right off the bat, you say, what's going on with this guy? Is it metabolic? Is it neurological? Is it immune? What, you know, it can be a combination. Is it depression? You know, who knows, right? So then you go to your exam, right? I'm not going to go through the whole history. Everything, what they tell you is they went through every test possible and everything came back normal. You look right away at his blood pressure. His blood pressure is around 123/76. His heart rate 65. He lies down and he's at 117/65 with a heart rate of 62. When he stands up, his heart rate only goes to 69, but his blood pressure drops to about 108. So his blood pressure drops about 11 points. You know, it's borderline, you know, but to me, it's something to consider considering his symptoms, right? And he's already failed. They told me he's failed a tilt table test. So, you know, he's been diagnosed with dysautonomia and he's on a beta blocker, and he's on a sodium type medication to improve his blood volume, right? And so overall, you could see he still has a little dysautonomia despite the medication. Here's the thing to think about. Now I'm going to ask you a question. The patient reports he has double vision. On VNG, his left eye comes out, and he's wearing glasses, and he tells you that in order to stay single, he needs to wear his glasses, but there's no prisms in the glasses. And so you would think if there was double vision, or if there was an aphoria or atropia, and he has, without glasses, an exotropia of his left eye, meaning that his left eye shoots out. With glasses, they come in. His history is when 4th grade, he got mono. And ever since he had mono, he's never been the same. In 4th grade, he developed massive dysautonomia, and they called it like an encephalopathy. And he's been symptomatic ever since, right? He hasn't been in school his whole life. He's got blurry vision of the left eye. And I'm going to give you the answer since we can't communicate. That what they did with the glasses is his left eye, the lens is like ridiculously magnified compared to the right eye. And the only way he gets both eyes yoked is by having a high magnification of the left eye. And so, and his pupil's a little bigger. And so right off the bat, you've got to wonder, why does that work? You know, that doesn't make a lot of sense. It's not what you see a lot, but you're going to say his left eye or left vision is different than his right side vision, right? I mean, can we all agree with that? If you're magnified on one side versus the other, you've got different visual system. And hopefully the first thing you would look at is you would say, what's going on with the optic nerve, right? And all of a sudden you've got an optic nerve issue. You've got diplopia. You've got eyes that are not conjugate. He has a balance issue, and he's got some headaches and chronic pain, and he has some vertigo. So that is the consultation. And by the way, I'd check, and just throwing this out there, and this is not a knock on anyone. I've been trained in development disorders, and I check primitive reflexes on everyone. I don't see a lot of them. I've been checking them on everybody for a long time. And I have Sally Goddard's book. I check it with a brush now, and I do everything I can to clean up my testing. But he did have an asymmetric neck reflex, tonic neck reflex, right? So he definitely had that, which, you know, and that was the one he had. And so here's my question to you. Like, he's got some finger tapping bilaterally. He's got some mirroring. He's got some dysdiadokinesia, you know, but just right off the bat, if you see an optic nerve issue, you see diplopia or double vision, you see eyes that are not conjugate, and then you add on a balance issue, you add on some chronic pain or even like a migraine. It's been going on since he was 4, and now since he was in 4th grade, which is what, like almost like 10, 11 years old. And now he's 24. So this is going on for 13 years post-viral. If you had one test to do, or if you're going to make a diagnosis, I'm going to put the question on you guys now. What does this guy have? Does anybody know? Or anyone have a guess? You could type it in, you could say it, you know. Anybody? I can't hear anybody. I can't see typing, so you just let me know. If you have no guesses, you could say, I don't know. I don't know.
We have somebody saying viral attack of the optic nerve.
I like it. So right off the bat, you're going to say, maybe it's a viral attack, or maybe it's an autoimmune attack, right? And so maybe the virus created autoimmunity. One way or the other, there seems to be optic nerve damage at this point, right off the bat. So that's constellation A. You're going to say that's significant, that he has an optic nerve issue. And then B, oh, by the way, he has no convergence. He can't converge at all. So then B, what else does he have that's significant besides the optic nerve issue? If his eyes are disconjugate when they move, which pathway is associated with that? Anyone know? I'll give you the answer, right? Just keep up time. Intracranial pressure, that's a good option. You look at intracranial pressure, you can do some imaging. I recommended an MRI for him because, and you could just keep this in your memory bank. If you don't know this, when you see optic nerve degeneration and you see disconjugate eyes that look like the medial longitudinal fasciculus, you should be thinking multiple sclerosis. right? And he's not a middle-aged female, but who cares? You should be thinking multiple sclerosis, and then you add a balance problem and pain on top of that, and you got some vertigo. I mean, of all the tests that they've done for how many years, the guy's never had a brain MRI. I mean, they've been around the world, the top hospitals, never had a brain MRI. They've had every other test on his gut, on his esophagus. They've done everything, blood work, never done a brain MRI. They have no idea if he has multiple sclerosis, optic nerve, MLF, rule out MS, do a brain MRI, right? So that's my morning case. And that's a typical day of somebody who sees 30 to 40 very qualified people. But because of our training, we can kind of make obvious diagnoses that people miss. And I could tell you most of my day when I look at a patient, which goes back to our original point, my number one job is to figure out what's wrong with people. I've caught 3 pituitary tumors in the last 3 months of people who came in with dysautonomia. I've caught conditions in the stomach, where you look at certain like superior mesenteric artery syndrome. I had a woman who came in from Mexico who was 30, and she's been passing out since she was a baby. And she literally comes to the clinic and says, I've been passing out since I was a baby. Every time I eat food, I feel faint and I pass out. And if I wear clothes and pants that wrap around my stomach, I pass out. And for 30 years, nobody can figure out what's wrong with her. And if you know what's wrong with her, it's obvious. She's told you what's wrong with her. She has a superior mesenteric artery syndrome, where part of your small intestine compresses on your superior mesenteric artery and your descending aorta. If you don't understand what that syndrome is, or what a medial ligament type syndrome is that can compress on your celiac artery, then you're going to miss it. And she goes to neurologists that do MRIs of her brain. She goes to GI doctors that do endoscopies, colonoscopies. Who's doing imaging? You know how we diagnosed it? A CT of her abdomen. It costs like $150 out of pocket. What doctor does imaging of the abdomen? It missed 30 years, right? It's an easy fix, whether it's fascial work or whether it's surgery, or at least just knowing what's wrong with you. You're seeing this more and more where things are getting missed. And as a chiropractic neurologist, it's important to be able to make these distinctions because some things are easier to treat than others. As a chiropractor, it's important to make these distinctions because I love chiropractic, but if you've got optic nerve degeneration and you tell somebody you're going to adjust them and you're going to heal them inside out, there's a probability that might not happen. Now, maybe it does, and maybe you got something magical going on that I don't have. And if you do, good for you. But for most of us, it's just not going to happen. You're not going to cure an optic nerve degeneration that's an autoimmune attack from a 11-year post-viral syndrome by doing vitalistic chiropractic work usually. And not saying functional neurology is going to cure it either, but you give people an appropriate diagnosis and appropriate prognosis, and then you treat what you can treat, right? And so these are I'm still going to treat them, and I'm still hopefully going to get them better. But we have a conversation up front about what's going on. And from a disability standpoint, if this guy gets worse and he can't walk and they don't get the right diagnosis, he might not be able to get disability. From a medical legal standpoint, a multiple sclerosis diagnosis is super significant. So I hope that's a long answer to your question. So our treatments are an hour long. It could be anything from vision therapy to vestibular therapy to, I do a lot of fascia work. I was trained with Ellis and under Ellis, so I do fascia work of the palate, of the skull, of the whole, wherever I got to go. I can tell you the past, and I've talked to Ellis about this, and I give Ellis all the credit for this because he reminded me about it. But I fixed maybe 5 different double vision patients in the last 2 weeks by doing myofascial work to the palate. And of those 5 patients, 2 of them had monocular diplopia, where they were seeing 2 and 3 out of one eye. And that all got fixed majority wise with palate work and fascial work of the palate. And so musculoskeletal work is important no matter who you are. If you don't need it, but it's important for a lot of people. Without that, I couldn't help a lot of people if I didn't do fascia work. So our therapies include that. We have vagus nerve stim. We do tilt table therapies. 80% of my clinics dysautonomia. Of that dysautonomia, almost half is post-viral or post-infectious Lyme, and almost half is post-vaccine at this point. If I talked to you 5 years ago, I would tell you 15 to 20% of my cases are dysautonomia, and most of them are concussion-based. If I talked to you pre-COVID, I would tell you 40% is dysautonomia, and it's concussion post-viral with a little bit of vaccine. And I have no bias. It is what it is. I can tell you right now, in the world we live in, 80% of my patients are dysautonomia. They're now coming in diagnosed with dysautonomia. It's not me diagnosing them anymore. They're getting tilt table tests from hospitals. and half of them are post-vaccine injuries, and the other half are non-vaccinated people who are post-COVID, right? It's a lose-lose, right? And so, it's no matter what your choice is, you can still get dysautonomia based on what happens to you. So hopefully that answers your question. Any other questions before we get started on the vision stuff? And again, I could talk to you guys whatever you want me to talk about. I'm pretty open book. So I want to make the most time of your situation.
Do we have any?
That sounds wonderful. So again, you can type it in. You can let me know if you guys have anything else you want me to speak on.
Did we answer your question, David? Okay, then let's get started on the lecture essay.
Do we want
Awesome.
to break down the MLF? That'd be helpful, like about convergence.
Do you understand why the MLF was the first thought here? Yes, no. Do you not? Okay, would you mind breaking down why the MLF was important in this case?
Without a doubt. And so
1 sec. There you go.
So multiple sclerosis can affect any part of the brain, right? It's a demyelinating condition. It's typically an autoimmune attack against your myelin, right? And you can go deep into maybe why or what the cause is. And again, that's a little beyond what we're going to talk about. But at the end of the day, there's some pathways that mostly get affected more commonly. Not for everybody, but the optic nerve is a common one. And the medial longitudinal fasciculus is a common one. And that pathway is the pathway that connects your two eyes together, and so that connects the left eye versus the right eye. So anytime you move one eye, it should follow it. And so when you start seeing one eye move independently versus the other eye, you start wondering, what is the pathway that connects the eyes and why is that not working, right? Interesting with him too, which was interesting, is we do like a light and indirect and a direct light reflex. And let's say you shine the eye in the right eye, his left eye falls out. But let's say you shine the light on the left eye, then his right eye falls out. Doesn't make sense, right? Because if you're right eye dominant, like most of us, and you shine it in your left eye, you're looking through your right eye anyway, and it really doesn't matter. And his optic nerve is that bad in the left eye, then I'll hear the case that maybe by shining it in the right eye, you can't see the left eye anyway, and he breaks. But by shining the left eye, his right eye should be dominant anyway. And so it showed again, his midbrain has issues. Just a little light stimulation, any vertical activity caused the dysconjugacy. And so it's really very superior to his brainstem when you look at where the injury was, because you could bring it on with light, you could bring it on in darkness, and you could bring it on with vertical eye movements the most. So it's horizontal eye movements were actually better. And it was only there a little bit in gaze holding at end range. It was the vertical eye movement that really, really came out. So that's kind of why I picked on it, because it's a common pathway that gets affected in multiple sclerosis. And anytime I see eyes that are like a lazy eye, we'll call it, anytime you see like a lazy eye or eyes that move independently from each other that shouldn't be, with an optic nerve issue, or one eye is way blurrier than the other, I mean, I run an MRI every time, unless there's an MRI already ran, they missed it. And I still treat that, whether he has multiple sclerosis or not MRI, I treat him like he is a multiple sclerosis, right? Like I'm treating it the same way. It doesn't impact what I'm going to do with him. I treat him like he is MS, whether the MRI is normal or not, but it impacts psychology. And I'm a big believer in psychology. And so it impacts his psychology of his ability to understand his condition and heal. And it also gives him some medical legal aspects. And it also gives him a lot of medical understanding and maybe some other medical options based on their biases, because we all have biases that dictates our healing and our decisions. And so maybe that allows them to maybe do some, when he gets bad headaches, they give him steroids and it helps him. Autoimmunity, that gives steroids, it helps some people, and so maybe it opens up some treatment options or IVIG that maybe can help them, so that's why I looked at it. Any other questions?
Anybody else? Any questions? Did you understand what he was just saying? Okay. Do you want to get started on the lecture?
I will. So I just said Carrick and gave him crap saying, why haven't I gotten these lectures, and give me an embarrassment. These lectures I did are for a medical school for a legacy project. They're sent to this. Originally I sent it as us, so I provided the president a copy. All right, I'm gonna try to get a copy of that from them. Anyway, so let's talk about what we're gonna talk about today. So let's talk muscle testing. My background's in muscle testing. I got helped by a chiropractor for Lyme disease a long time ago, and the guy did a lot of muscle testing, and I didn't know what he was doing. He had a lot of energy type medicine that he did, and I didn't know what he was doing, and it helped. And so before I ever knew anything about neurology, I was very big into energy medicine and muscle testing. Before I even knew what applied kinesiology was, I knew about muscle testing, and I muscle tested people, and I worked with Lyme patients as a health kind of coach. At the time, there was nothing, health coaches didn't exist at the time, right? Everyone's a freaking health coach now. But at the time, I guess you'd call me a health coach that worked with Lyme patients through muscle testing, from a lot of different ways, right? So that's my background. Then I got into neurology as a Dr. Carrick, and I saw it work. And so when you look at muscle testing, I'm a big believer in muscle testing and what it does. Muscle testing is a great indicator. It's not a great objective measurement tool, right? It's a great technique, and it shows you kind of great ways to maybe try things. It gives you some nice indications of things that may or may not work. It's a terrible way to say if you get anyone better, right? And that was never the purpose of muscle testing. Dr. Goodhart, who invented AK, never muscle tested someone and got strong and said you're better. He used objective independent markers that he used, and the muscle test was first tool, right? And so muscle testing is, in my opinion, is a great tool in order to understand muscle integrity compared to an external force. And we know that involves a nervous system. The reason we like muscle testing is when you look at organs have intrinsic nervous systems, meaning that your gut and your heart have intrinsic nervous systems. So if you cut out your heart and you put it in a petri dish in the right type of fluid, it'll still beat, but it'll beat too fast. If you cut out your stomach, it'll still contract, but it'll contract too much, right? The second gut in the brain is true, but it's a stupid brain compared to the real brain, but it's better than areas that don't have a brain, because what areas don't have a brain? Your muscles don't have brains, your glands don't have brains. And so these areas then are more sensitive indicators or objective markers to look at brain function, because you're not having to then take into account the actual secondary intrinsic nervous system of the heart or the gut. So we like muscle testing. We like looking at glandular function, which is a little trickier than muscle testing. And so muscle testing is a nice window of brain function, in my opinion. Doesn't mean the muscle's weak or strong, but it looks at, can the nervous system resist an external force that's not overpowering, and that you're not trying to cheat the system. When you look at, and I don't know how many of you guys, and it's a little tricky not being there, obviously, I don't know how many of you guys have done the master's program or know the global assessment or these type of things, because when you look at the global assessment, it's a nice tool. I see someone walking to the front, so she might want to tell me people are here, no muscle testing, they don't know muscle testing, because we could do a lot of hands-on if you do. We could do a lot of hands-off if you don't, and so it's really up to you of how you want to do it. I'm all for hands-on. I like hands-on. I'm a believer in hands-on. I think too many people teach neurology and clinical applications that are clinically inept and couldn't treat a patient if their life depended on it. And they're stealing your money because they're teaching you things that they have no idea if works. And so I'm a big believer that you should see people in their clinic. Hang out with me, see me work, see me fail, see me succeed. No ego. This is the reality. I'm not a believer of people who teach and never let you see them, because usually they're full of what, and they're happy to take your money and tell you what to do, but they'll never let you see a patient. So I only trust people where I see people treat, and those are the people I listen to because I've seen them treat people. So having said that, we want to do as much hands-on as possible, because that's how you get better, And so raise of hands, because I could see that. Raise of hands, who here has done muscle testing before? Cool. Raise of hands, who has not done muscle testing before? Cool. So people can help each other out. And so when you look at the global assessment, I know some of you guys, I know I was talking to some of you guys, and you guys are with Dr. Rao, or, I know Sophie, we talked. And so you kind of help out. So we'll start a little bit with the global assessment, and let's go right into it, right? And let's get some hands-on, and let's do some things at the end of the day, so you're not just sitting me talk and I can't listen to you. And so the first thing we do is, why don't we, Sophie, because I can see it, why don't you bring somebody up and you could be my tester and you could test somebody? That sound good? And again, feel free to tell me no. You can tell them, you could say don't do it. I don't want to do it, but I think this is better. And again, we got 2 clinics in Illinois, 1 in Florida. Come hang out. If you want to hit me up, we let people observe. The only way to get better, you got a lot of people in Atlanta, right? You got Dr. Ellis right there. You got Plasticity that's still around right now. You've got, Cedric and them just opened up a clinic, and there's a bunch of people there. You've got my buddy Jerome over there, who's pretty good, and he's good with what he does. I don't even know what his clinic looks like anymore. That's what I'm saying. I think he does a lot of kids still. I haven't talked to him in a little bit, but Jerome's really good. You know, I think now you've got, what's his name that opened up with Brain Chat, Ryan Cedarmark, right? And so you got Cedarmark and them opened up, and you got the Life Clinic, right? And so what's interesting is you've got all these clinics, and I could promise you they're all different, right? They're probably more similar than compared to like a medical clinic, but they're all doing different things, and you should go hang out with all of them, right? There's no bias, right? Like people have different groups of teaching. It doesn't bother me. I've got no biases. I don't hate or love anyone based on affiliations. You should see them all, and you should see what works, and you should see what doesn't work. And you should take the good things out of all of them, and you should really observe the bad things you don't like out of all of them and figure out what you want to do, right? Because I could promise you, Ellis is different than Frank and Duffy, who's different than Cedarmark, who's different than Jerome, who's different than Cedric, who's different than Vita, who's different than Ben Barron. You know, they're all different. They're all good. So you should check them all out. So you have a patient up there lying. Cool. So let's do this. So let's just go through a few simple muscle tests. So let's do a straight leg hip flexion. So leg comes straight up, and then you just muscle test straight down. Good. That's one. And then you can do the other one. And here's the key with muscle testing. You start light and you slightly increase your pressure till you find a meeting point, and you say, that's about how much they can do. And then what you can do is then you push a little bit more, right? And just a tiny bit and see if they can resist. And while we're there, let's just keep it simple. Now what you're going to do is you're going to do the same test, but now you're going to externally rotate the foot. And so the same test, you're just going to hit it down a little different plane. Good. And you're just going to say, when I rotate the foot, is it the same as when the foot's forward? And then you'll do it again, internally rotating the foot, right? So it's still S to I. And you're just going to look at different planes and say, when I rotate the foot in, internally rotate, what does it do? Externally rotate, and see if there's any difference based on hip rotation with the same motion, right? And so that's the first thing you could look at. Next thing you could look at, and that's right, and up and we'll say that's in a vertical plane, right? Next, you could look at more in a horizontal plane. So you're just going to take the leg straight out, and you're going to do almost like what you might look at as like a long lever medial glute test, right? And then you're just going to push in, and you're going to see how that holds. And then you can do the other side. And then the same thing, you can do it, bring it out, and you can externally rotate the foot. And same exact test. So it's still the same exact plane. You're just putting different planes of the body into the vector of tension. And then you could internally rotate the foot, right? And you could just see, how does that hip rotation change your muscle test, because you should be stable in all of them. And then last one we'll do is we'll do like what you might see as like a TFL test or tensor fasciae lata. So you're going to come out in like a 45-degree angle. So you're going to come up and out. Yep. So, and then you're going to push in, down and in. And then you go down the other side and the same thing. So right off the bat, you have 3 long lever tests. And the idea is you're lying down, so you're removing gravity. And what you're really doing is you're seeing, does the core stability create enough stability to resist tension on an external lever or on an extremity lever? Or say differently, you're taking a long lever, right? This is not AK by any means. This is like the antithesis of AK, right? We're doing long levers. We're not very specific to any muscle. We're going over multiple joints. In fact, our hand might even be on a joint, God forbid, right? And so this has nothing to do with applied kinesiology. But what you're looking at doing is saying, can this plane of muscle or fascia, wherever you want to look at it, of the leg, resist this activity, or can it not? Everyone follows me? Did you get anything weak there? Yes or no? Give me, yep, let me know. You can type it in, just yes or no, anything weak. Nothing weak. Cool. So now let's do the upper extremity, and we'll do the same thing. Where the first thing we'll do would be more looking like, let's say like a straight arm pull down, you know, like the muscle testing most people know about. That's really anti-AK again, where you're going to arm up and you're going to straight pull the arm down, like a straight pull down test. All right, and you're just going to check it. Then what we'll do is that's one plane, and then we'll do like a pec-clavic test where you come up, the hand or the shoulder internally rotates, the palms facing out, and you're going to go medial to lateral to try to get the muscles of that pec-clavic kind of going. And then finally, you'll do like that pec sternal division where it's long lever, and you're going to go kind of back at a 45-degree. And so you're going to get more of that pec sternal division. Good. And write down any weak muscles or no. He had some weakness, right abduction. Okay. And then everything else is strong. Is that correct? So right abduction, is that right abduction of the hip? Is that correct? Hip, cool. So let's start there and let's walk through a few things, then we'll do like a breakout session, okay? So right off the bat, why don't we sit him up? Or her up, I can't see if it's a him or her, so I apologize. And then let's retest the shoulder muscles that you just did. And then once your shoulders are tested, do hip flexion. So bring his hip up and just do like a straight push down. And then once you do that, type, was anything different seated versus laying? It may or may not, right? You don't make any assumptions. You just test and see what happens. No difference. Cool. So line back. Let's actually stand him up and check the shoulders standing, just the shoulders. And let's just check one more time, and then we'll get into the challenges. And then again, once you're done, just type no difference or different. And again, it may or may not, right? So no difference, right? Cool. So let's have him line his back. So we're gonna, for this patient, we're gonna start with that right abduction, right? And that's gonna be our indicator muscle. We like finding muscles in the weak and the clear, right? That gives us a little bit of a weakness in the system versus finding a strong muscle and seeing what weakens it. We always typically like to prefer to find the weak ones and see what strengthens it. So right off the bat, let's our first challenge. Let's just go through the challenges so we can talk about them, and then we'll break them out one by one. And so our first challenge, let's challenge it eyes open and check the muscle, and challenge it eyes closed and check the muscle, and tell me if there's any difference, yes or no. He's gonna get like a nice hip workout today. Do you look at hypertonicity? I do, but I'm going to be honest with you. I look at hypertonicity based on neurology. Is there spasticity? Is there clonus? Is there hyperreflexia? As far as hypertonicity in a muscle test, I look at it, my opinion's a little different as far as what that means. So I'll fix it very differently. So like from an AK perspective, I'll fix that in a very different way than the way it's taught in AK, because I think it's misinterpreted a little bit. If that answers your question. Again, ask me any questions, AK, muscle testing, anything. I'm neuro, I'm happy to answer anything. And if I don't know, I'll tell you I don't know. So stronger with eyes closed, right? So right off the bat, that doesn't make sense. Why is his right hip abduction have anything to do with his vision? I used to be a personal trainer. That's not what I learned. You know, in chiropractic school, do you learn that? You know, do you learn the nerves that go to the glute med, and what parts of the spine it comes from in the low back, and what areas, pathways it goes through for conscious, unconscious pain, areas of the brain it goes to, brainstem, but the visual system makes it change. It does, right? Because your visual system is going to input what's going on in your environment, and it's going to give you a basis of your movement. So if he's better with his eyes closed and eyes open, right off the bat, we're going to say that there's something going on in his visual system that's impacting his postural stability, his postural stance. Does that make sense? Right off the bat, because if his eyes are closed, he's more stable. Something is going on in his visual system, and the way his brain is computing his external environment is shifting his muscle tone to create a balance that causes weakness. So right off the bat, eyes open, eyes closed gives you a nice window of your visual influence of your movements and of your muscles. And you could do this with a muscle test. You could do this with a figure tap. You could do this with a figurative nose. You could do this with a squat. You could do this with a pistol move, right? You can do this with anything. It's how does your vision, balance testing, how does your vision influence your movement? Right. So that's question one. Next one. Let's cover his left eye, have him cover his left eye and test it, and then have him cover his right eye and test it, and tell me if one's different than the other. And then let me know, is one different than the other, or are they both the same? And you just type it in. Weaker with his right eye covered, but really what you're telling me is he's stronger with his left eye covered because he started weak, right? And again, we like starting with weakness. And really what we're saying is, because here's the reality of the brain, of how I look at the brain. One of the realities I look at the brain. Your brain is about efficiency. Everything about the brain is efficiency. Your brain is only going to use the pathways that are efficient. If any pathway is less efficient, your brain won't use it. It's like a road that's a highway, like an Atlanta highway that's got freaking 20 lanes, but they all got potholes. Your brain's going to use the side road with no potholes. And until you fix the potholes, it doesn't care. And the more you don't use it, the more you lose it, and the more potholes come in. And so to me, what I do is I'm all about my exam is finding inefficiencies. And that might be frank pathology, right? But it's inefficiencies in the system. And then my therapy is about making the system more efficient. That's what I do every day. And so when you look at the brain is about finding pathways that are inefficient and doing rehab to those pathways to make them efficient. And there's no freaking supplement or drug that's going to do that that's specific to a pathway. I have a whole closet full of supplements. We talk nutrition, we have no problem with drugs, but you use things for what they're appropriate to. I'm not using eye movements to fix diabetes, and I'm not using supplements and medication to fix neural pathways. Right? And take it to the bank. It doesn't make one better than the other. It makes it super inappropriate to do one for the wrong reason. And when people do teaching seminars and only do one thing, it's motivating to them to tell you that one thing does everything, and it doesn't, right? We do supplements, we do nutrition, we do rehab, we do neurofeedback, we do hyperbaric, we're adding IVs, we do the things that make sense to help people that we want to help, right? And by being dogmatic, you're going to miss things, you're going to not help people, and you're going to have a poor business model because your dogma and your psychology is influencing too much of your clinical decisions. So what we're really saying is with his left eye covered, he's stronger, because the point is with his right eye, he's creating efficiencies in that system that create more hip stability. When you look at your brain, your occipital lobe has cells that only detail the left eye information, and then has cells that are only right eye only. And then these visual pathways then fire forward and feed forward into the parietal lobes and frontal lobes and temporal lobes to give your brain information about your visual system. And if you have a visual suppression or a visual dominance of one eye versus the other, you're going to start creating plasticity in one eye versus the other, and the other eye is going to be less efficient, and that eventually can create problems, and that can create double vision, blurry vision. It could be associated with dysautonomia, visual problems. So right off the bat, we know he's better with his eyes closed, and so we know he's got a visual issue, and then we know he has one eye that's different than the other, and so we know we're probably going to start with therapies that are going to be right eye only, and eventually transition to both eyes, at least for this muscle. We might if you're only looking at muscle testing, we might test another muscle and come up with a completely different answer. Typically not, but you can, right? But for this answer, that's what we're getting. Next, we're going to look at depth. So this is actually pretty interesting. And so we're going to need a little help here. And what you're going to do is we know his eyes open, his muscle's weak. And so we're going to give him a fixation point, not in convergence, maybe like, I don't know, 18 inches away. And he's going to look at that point. And you're going to test the muscle, and then you'll go another 6 inches away and test the muscle, then another 6 inches, and you're going to find at a certain depth point if you're able to find the muscle strengthening. And you just let me know. You may or may not. So first, it's nothing. You just check it. He's just looking at the ceiling, and then he looks at the finger about 18 inches, and then 24 inches, and 30, and 36-ish, and then you keep on going. And you just let me know if there's some depth perception or some area of his depth field that causes it to be strong. Stronger with 18 inches, weaker closer, and then how about further than 18 inches? So keep going further and tell me if it gets weaker again. or if it stays stronger. Yep, and just let me know. If it's, everyone's different. So some people might be really strong until they get too close. Some people might be one distance, that's good. Everything else is weak. So you find for each person, what's what. And so you just let me know after 18 inches, if is he strong or weak when you go further than 18 inches. Weaker after. So how screwed up is that, right? And so closer than 18 inches is good. Further than 18 inches, I mean, it's not good. Further is not good. Right at 18 inches is a sweet spot. And so what you're really telling me is that at 18 inches, when his brain is happy, the second is closer or further, his brain isn't happy anymore, which is kind of sucks because things are mostly not in 18 inches away, right? And so that's not so cool. And so there's therapies that we do to fix that, to make 18 inches the same no matter where you are, right? And so there's a lot of therapies you can do, and we'll talk about these things, but right now we're just kind of playing with it. And we're going to say that's his sweet spot when it comes to his depth of what his brain likes, Next, let's do this. Any questions so far? I think that's good for right now before we keep moving. And so why don't we do this? Why don't we take like a 5-minute breakout, and you guys can kind of all muscle test each other. You can do it seated, standing, lying. You could test whatever muscle you want to test. Once you find a weak muscle, what you're going to do is you're going to use that as an indicator. And what you're going to do is do eyes open, eyes closed, one eye versus the other, and then depth. And you're going to tell me, and you're going to write down your findings, and everyone's going to say if you can find that weak muscle. If not, have someone help you. And you're going to start challenging everybody and seeing if they visual dominant, is one eye more dominant than the other, and if they have a certain depths that they're good and bad at. And I'm right here. I'm not going anywhere. So if you have any questions, let me know. But let's take 5 or 10 minutes and let's start getting hands-on. And can you guys still hear me if I talk while you guys do practicals? The mic is still on? Yes, no, thumbs up, hands up, the mic is on. Hello, hello, anyone? Or am I muted while you do practicals? Okay, so you hear me. Okay, so you hear me right now. While you go, let me talk to you about a little bit of supplements. It's hard to over everybody. All right, never mind. You guys keep doing your thing. You just let me know when you want to move on. From a GMA perspective, do you have a reason for why we use lateral flexion for upper cervicals and rotation versus lower? I think it's really just the reason it's thought about is just biomechanics, or theoretically that lateral flexion is going to be more involved with the upper cervical spine. When you look at rotation, it's a little more involved maybe with that middle area. I don't know. I think that's kind of the theory I've been told. I'm a believer in intention, and I think a lot of muscle testing is intention. But there's definitely a biomechanical aspect. It's almost like the activator method. You really can't tell me that those moves in activator are specific to spinal segments, but it still could work. So, I think intention is part of it. And I also think biomechanics is a part of it, where maybe that lateral flexion is a little more specific or sensitive to that, maybe, or maybe honestly, if I have for me, again, that's not what I do. So I'm just trying to rationalize it from the GMA. What I do is like I said, if you challenge lateral flexion, I'm probably going to adjust you in a lateral flexion manner. If you challenge the rotation, I'm probably going to rotate, probably going to adjust you in a rotated manner. You know, so that my challenge will probably be my setup. I'll write it down.
Anybody have some cool findings on their partners? Yes, Brandon? Yes? Do you want to tell us about your findings?
I tested Andrew, I just did your voice.
Uh-huh.
He's strong in everything, anterior delt, medial delt was a little weaker, but everything was weak with posterior. He did get stronger when I had him hold a plastic bottle. I had him look at the tip of the bottle. It's about a foot away from his face. 12 inches, maybe like 15 inches is where posterior delt got strong.
Okay, so we had some changes between weak and strong with distance, just like we did for you too. Did anybody find some other findings with eyes open, closed, or maybe seated versus standing?
Yeah, we get some big difference, when we tested Kelly, when she closed her left eye,
Mhm.
her right eye, she got significantly stronger, the test changes, significantly, so the right single, the, left eye was great.
Okay, cool.
Right.
Awesome. Anybody else? Any cool findings?
My right side is really weaker. And one side maybe my easy so
But did it get stronger with any challenges?
yeah, like I flipped my hand. So I think I stronger.
Oh, well, okay, yeah, so classic AKA therapy localizing. But is there, did you try to change it with eyes open or closed or anything like that? Okay. All right, then I think we're gonna continue. I'm gonna turn your sound back on.
So you guys can hear me? So if you can hear me, everyone could hear? Just give me a yes or no in the chat if you could hear. Awesome. So let's just talk real quick before we move on. If you've got a weak medial glute, what are the probability, and it gets stronger with one of these challenges, what's the probability it's a nutritional deficit? What's the probability it's a meridian issue? What's the probability it's an organ issue? Or what's the probability that this is stemming from a brain imbalance or a brain issue or something with the brain? And what I'll tell you is I'll fix a lot of things without touching the body when it comes to muscle testing by doing a lot of stuff. And if it's an acupuncture issue, or if it's an organ issue, or if it's other issues or emotional issue, these things will stay weak, right? And a lot of things, if you treat weak muscles that are not the great indicators, like for example, if that glute med is a reflection of poor brain processing of its visual vestibular integration, and you keep treating it as like a sexual dysfunction, or you keep treating it as large intestine, or you keep treating it as an emotional issue, or you keep treating the ileocecal valve, or you keep treating as a bowel or as lymphatics, and it's just a reflection of visual vestibular integration, you might help other stuff because that stuff is good to fix, but like you're not fixing his visual vestibular integration, which is the root cause of it, right? And at the same time, if it's an organ issue, doing visual vestibular integration is probably not fixing that either, right? And so I like fixing the brain first and cleaning up all the weak muscles as quick as possible. And from an AK perspective, then looking and seeing what's left over. What do I got therapy localized? But at this point, like I do a lot of fascia work and muscle work. I fix pain in the body more times than not without touching the body. And then I'll touch the body because most people that I see have chronic pain and central pain syndromes, you can't touch these people, the kids can't touch them, no one can touch them, so forget about adjusting, you can't touch them, the kids can't hug them, like you can't touch these people. So what you got to do is you've got to get rid of their pain by not touching them. And once their pain's gone, they're typically going to have some mid-back pain or low back, then they'll have the musculoskeletal stuff that works, and then all of a sudden the therapies that didn't work before now work. Right. And so this is the way I treat people based on the patients I see. If you're in more of a musculoskeletal practice, this might not be as significant unless someone gets a concussion or a car accident, because people are relatively healthy. You might not see this as much, I see pretty unhealthy people sometimes, but pro athletes I see all the times too. And you'll pick this up in pro athletes all the time, So next thing we'll do is we'll start looking at peripheral vision. When you look at peripheral vision, there's two ways you can look at it. You can look straight ahead and you come in from the center. And then you look straight ahead and you keep looking straight and you just slide central to peripheral. So again, why don't we bring someone up there? You guys, and it doesn't be the same person. Everyone's tested some stuff. So someone who knows they've got a weak muscle, and let's bring someone up there and let's just have a weak muscle and we'll test and we'll go through the next challenges. And then you could just let me know which muscle is weak. And so I could just talk to you guys about it. And again, whenever you have it, you just check it and then just type in which muscle is weak. That's in the clear, eyes open, looking at the ceiling, etc. And the nice thing about this stuff is you can do this and just middle low trap weak bilaterally. Okay. So the nice thing about this is, let's say all you want to do is adjust somebody and they get strong with the right eye open. You know what you're going to do? You're going to cover the left eye and you're going to adjust them with the right eye open. Right? It's that simple, right? And so you don't have to. That's not necessarily what I would do. I'd fix it first and I'd adjust them after it's better. So it's not what I would do, but it's definitely a therapeutic option that makes sense and that could help a lot of people versus keep adjusting with both eyes open. And you're going to keep driving the imbalance over and over again and both eyes are open. And so if you've got that visual imbalance, you could cover one eye and do the adjustment with the eye open. That strengthens the muscle. And then what you're going to do is you'll open up both eyes and you'll see if the muscle goes strong. And most of the time it will. You know, like I said, I do vision training and things, binocular, but it works really well too from a musculoskeletal standpoint. And so middle trap weak bilaterally. So now what you're going to do is you are going to have them look at the ceiling and you're just going to come from the right to the middle, the left, you know, like 18 inches-ish here, from the 4 vectors from periphery to central and test. And then you go central to peripheral and then you test central peripheral. And so we call these retinal slips, you know, and these are major midbrain mesencephalic activations when you look at these retinal slips. And there's a lot to do with our brain processing motion. And so instead of having them follow like a pursuit, we're going to have them look at the ceiling and we're just going to come into its center field and test each direction. And then we'll come away from the center field and test each direction. And then you'll just tell me if any of them get strong. Peripheral vision training is really important for concussion prevention. It's really important for prevention rehab. It's really important for the brain, you know. Peripheral vision training is very brain active. Bilateral strong, peripheral to central in all directions or peripheral central in only one direction? Cool. So that's what you want to know. You want to know which direction does it get better on? And a lot of times you'll see that correlate with your pursuit testing. Because your retinal slip is your precursor to a pursuit movement or an optic following. And so what you can do is you can pick up these retinal slips. So it gets stronger in all directions on the left, and let's check the right. And so if his retinal slips get better, then this is a great candidate for pursuit following training. All right, only stronger in upper quad. Retinal slip is a precursor to an eye following motion, meaning a pursuit or an optic following, like an optic kinetic reflex. So now that we see that, how is it going from peripheral to central? You know, is it any different peripheral to central, or is only central to peripheral get stronger? And also you can see this might strengthen on one muscle, it might not do on the next one, you know, and that's okay. Weak central to peripheral, the left and right. How about top and bottom? So it stayed weak periphery to central. So now I want you to have him go like from top to the middle and then from bottom. So look at his peripheral vision. You said it was still weak from left to right. So now I want you to look from like top and come down to his middle vision and from bottom. So it's like a peripheral target that comes from inferior and superior. You just let me know if there's any difference up and down. Strong left, both top and bottom, right was weak. All right, so here's your options, right? And so let's say you get better with peripheral, central periphery. What this typically means is we're going to be doing a lot of pursuit following training, you know, a lot of eye head training, a lot of eye following training. We're going to be doing a lot of that. When you look at getting stronger up and down, that means we'll do a lot of peripheral reaction training, a lot of ups and downs, right? And so I'll correlate my peripheral to central as far as like reaction time training, ball catching, Marsden balls, things like that. And then I'll do forward to back, and we'll do a little more pursuits later, but forward to peripheral or central peripheral. We'll look central to peripheral, looking more pursuit following. And so that's gonna give us indicators of the pursuit. And while we're there, let's do one more thing. Check his pursuit. So what you're gonna do is you're gonna have him follow to the right, hold his eyes to the right, and challenge it. And so you could have someone else do it if you want. And what they'll do is they'll follow the eyes to the right and you'll test the muscle. No problem. What you can do is you can actually follow the finger to the right, nice and slow, hold the eyes and test the muscle. You can then follow to the left, hold the eyes, and then test the muscle. You could then follow up, hold the eyes, and test the muscle. You can then follow down, hold the eyes, and test the muscle. So what I was saying was that when I see people from central to peripheral, I think that gets stronger. I think about a lot of eye head following, eye head pursuits, times 0, times 1, times 2, different backgrounds. When I see things that get better from peripheral to central, I'm thinking more reaction time training, peripheral field training, Marsden ball training, those type of things. Yep, question. And again, if I'm going too fast, I'm happy to slow down. Um, the problem with the muscle testing is it can always have an impact, right? And so this is why muscle testing is a terrible indicator of whether you're getting someone better or not, because in my opinion, your intention matters on a muscle test, but that intention is not going to matter on your balance test, on your finger tapping test, on your saccade test, on your pursuit test, or any of your neuro testing. And so in my opinion, if it does, which is why when you test this, you don't want to have a preconceived notion of what's going to happen, and you don't want to influence what's going to happen, because intention, in my opinion, does matter. And so from a more basic standpoint, the second you add intention to your muscle testing, you are creating it to be more subjective. And it doesn't mean it can't work or it won't work, but it means that you better be really clear and very intentional on your every second of your life, because all it takes is 1 second of inattention to ruin your muscle tests. And so from my perspective, the better way to do it is to not think about anything and just muscle test with no thoughts and just see what happens, and then just challenge these things with nothing in your head. Because if you manipulate the muscle test to shortcut things, again, it's not saying it works or doesn't work, but all it takes is a split second of focus, looking away, or just not being locked in, no matter how locking technique you use. And it's not the best indicator, if that answers the question. But you'll find someone might get a weak muscle, someone might get a strong muscle, and it might be their technique, or it couldn't be an intention, and so it's something to consider. Anything else? So how is his? So left pursuit was strong, right pursuit was strong. Of course, that was Tommy. How you doing, Tommy? Right pursuit strong. And then what we're gonna do is, how about up and down pursuit? Do you test that? They test that? Cool. I like this view. This is a cool view. Yeah, so what'd you get? And again, you got to take with a grain of salt, the distance of the movement, and convergence, etc. But, based on that movement, up and down, did anything change in those pursuits? See, up and down, good, left. All right. So again, So what typically happens is a lot of times you'll see correlations with the retinal slips and with the pursuits. And so what this will tell me, and again, what we're just so we're all on the same page, this isn't necessarily what you're going to do every day with a patient, but if you want to create a multimodal rehab program, this is going to give you a lot of data points that you can start to correlate. And like that's what we're going to finish off with today is how to take all this information and create a rehab program, right? Because at the end of the day, you're not going to do this every day. Like you said, this is to me could be an assessment. That's part of your assessment to say, okay, part of our interactive rehab is we might do something with an eye patch. We might do things following left to right reaction time, up, down, head movements. We might do things eyes open, eyes closed. We might do things more right field versus left field. So depending on what gets strong, I'm going to take what gets strong and I'm going to take everything that's strong and I'm going to put it into one program. Does that make sense? And so I'm going to take all my challenges and I'm going to put them all into some program that utilizes them all. And so I could fix everything all together. And so we did pursuit. We did the peripheral vision, peripheral to central, central to peripheral. Let's do one more and then we'll test. Let's do saccades. And so you can do the same thing where you're going to test him and you're going to say, look straight ahead. Now look to the right. And while he looks right, you test it. While he looks left, you test it. While he looks up, you test it. While he looks down, you test it. And then after this, we'll break out and we'll do more muscle testing hands-on. So again, you give him a target, you could have him just look at a target himself, and they're different to the brain, but again, the test is a test, so you just do it and see what happens. But there's difference between like overlay saccades and express saccades and visual targets and non-visual targets, etc. And again, if you want me to repeat anything, I was speaking fast to try to get to clinical apps. I'm happy to slow down and repeat anything you want me to. I'm able to talk slow if you want me to. And you can just type in up saccade is good, right saccade is good. So I'm going to be honest with you. Right, we see improvements in a lot of these tests right now with them. Can we all agree with that? Right, in all directions. A lot of times you only see it unidirectional. When you see things like left, right, up, down, saccades all get better, to me, my first thing is, and again, I don't know this person, so don't take anything personal. This may or may not relate. But to me, my first thought is what's going on in the brainstem, and what's going on in that brainstem, because no matter what I do, when I integrate into that brainstem, I'm getting changes in that muscle activity. What does that mean to me? It means that when I do these things, the muscle gets strong. That's what it means. But for me, I'd be curious in his blood pressure, his heart rate, lying to standing. I'd be curious about his pupillary responses. I'd be curious about his stress responses, his sweat responses, his digestion, his immunity, right? These are all things when I look at these brainstem responses, pain, I'd be curious about all these things, because all these challenges are coming up strong and they're not very specific, right? They're kind of global activations. And so this is why muscle testing is cool. Yeah, who hasn't, right? It's kind of a cheating answer, right? And, turn on the media, go to school, live in the world today, breathe air, drink water, eat food, at some point, live life. It's stressful. But for sure, I mean, does that make sense though? It's like everything, typically you see thing one direction or the other. When you start looking at this global activity, you're like, I could do a lot of stuff in rehab, or I might be able to do one thing and fix everything. And then I can retest this all, and then I'll find something more specific. Like in my clinic, let's say I did this, I'm looking at this and being like, I'm going to fix this completely different. This is too many strong challenges, and I'm going to fix this in a completely different way. And I'm going to come back, and only one of these is going to be positive. Right. And as you guys do these breakouts, you'll probably find in most people, not every direction is going to turn it strong. And when it does, you start looking at it and you look at the physiology behind the challenges, right? The problem in applied kinesiology and muscle testing is when Dr. Goodhart was around, all of his techniques, he read science, and whether it was right or wrong, you liked it or not, he provided research for why he did something now. Nowadays, after Goodhart died, most people give you applications based on their own reasoning, which may or may not be true. Right. And so what I like to do is correlate the muscle testing with objective markers and have an understanding of why things are the way they are. And so when I look at these eye movements, all it tells me is if I understand the physiology, I can say right saccade, left saccade, two different sides of the cerebral cortex, both burst neurons, but then the vertical one strengthens it too, and the midbrain strengthens it, the PPRF strengthens it, the pursuit strengthens it, the vestibular nuclei then strengthens it. Those parietal pathways are different. So everything that feeds into that brainstem is strengthening it. All this corticopontine, all the corticomesencephalic, all this top-down regulation strengthens it. And so the question is what's going on in this bottom-up system? And what's going on where all this top-down activation is causing some stability. There's a high, like maybe it's old concussions, maybe it's old sicknesses, maybe it's stress, but that cerebellar brainstem basal ganglionic circuitry in that type of patient is typically not as intact as it can be. And you could fix these really, really, really quick and easy when you see this type of stuff, And so I can tell you right now, in 1 or 2 sessions, you could fix most of this. And then whatever's left over, then that's the hard stuff, But, a lot of functional neurology, if you do it well, you can do it really quick and very simple using very simple exercises with no technology. And so if there's no other questions, let's break out and muscle test again. And let's do, again, the peripheral vision, central to peripheral. Your peripheral vision, peripheral to central. Then your pursuits, holding it, and then your saccades in all 4 directions. And then you test, and then let me know when you guys are ready to discuss more. Let me know when you could hear me. Cool, everyone hear me? So that at the very least should give you some good windows to say if saccades in certain directions make the muscle stronger, then there's a probability that that brain activation is creating more efficiency in the brain to help out your musculoskeletal system. And at the very least, there's an indication to say if rightward saccades made you stronger, then give someone rightward saccades at home for therapy. Right, and just make that pathway more efficient, create plasticity in that pathway. If pursuits and direction made them stronger, create a little video or PowerPoint or focus builder or whatever you want to use, and just start giving it to people, right? Training people's pathways in that are efficiency in those pathways. I relate the brain to patients like, you have an area of the brain that can do 20 things, an area of the pancreas could do maybe 2 things. And those 2 things are important in the pancreas, right? But in the brain, you might do 20 things, and all 20 things electrophysiologically are activated the same way. And all 20 things might be completely different. But if your eyes can't go well in one direction, then that area can't do anything well. And that also might be involved with cognition, emotion, autonomics. And so if we can get these eyes more efficient and those cells more efficient, and they'll be more efficient in every task they do, right? And so this isn't about getting better eye movements. It's about getting people better brains to translate into better function. The eye movements are just a window and a method of activation to create multimodal plasticity and rehab to change people's symptoms, functionality, or function in a positive way. So let's bring someone else up. Let's do a few more challenges and then we'll put it all together. Because I like these ones we're about to do. And these are the ones I use more in my clinic every day. So I'll do a few that I do every day. Not that I don't do this every day, but I don't, like I don't muscle test a lot of people anymore. I do it other ways. Or to say it differently, if you could hear me, this is what I do every day. I just don't do it through muscle testing anymore for a lot of people. I can, but I use what I think are better objective measurements. So it doesn't confuse me as much because muscle testing can be confusing. Cool. So find a weak muscle. Let me know when you got one. Let me know what you got. So type in, if you got a weak muscle, just type it in. We got a weak left hip flexor. Sweet. So let's keep that. Let's keep it there. You don't got to change anything, or you can lie him down, whatever you want to do. And so what we're going to do is either lie him down or sit him, whatever you guys want to do. We got that weak left hip flexor. So now what you're going to do is you're going to passively rotate his head to the left. So take his head and passively rotate it to the left, and then recheck the muscle when you're done. And now passively rotate it to the right. Is there a difference? And so you can write down, is there a difference between passive left head rotation and passive right head rotation? Right rotation is strong. Now let's do it active. So with your head, you're going to turn your head left and then check it. And now active, turn your head right and then check it. And tell me, was it different or was it the same? What are your findings? Well, there you go. So tell me again, what's going on with his neck? So right off the bat, if you rotate the patient's head or if they do it themselves, it's a completely different thing to the brain, right? Most people don't think about neck, 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 neck. What's the difference? And this directly correlates to the master's program and what Dr. Downs and Dr. Rao teach, because this is the difference between a passive movement, which is really the force is generated by an external force. So you get more bottom up stimulation from the neck. Your passive movement is going to be more reflective of any neck imbalances. The second there's an active movement, that movement is generated from the brain, right? And then that generation from the brain involves a feed forward activation, some feedback activation, and an efferent copy. And so I'm going to talk to you like you don't know what that is. A feedback activation is the feedback from the muscles in your joints and your vision and your inner ear and all the systems that tell your brain where your body is. Feed forward activation is typically the stability that your body needs in order to stabilize your body to create forces or perturbations of your limbs. So like if you swing your arms, typically around 100 or 150 milliseconds before the movement to, maybe a 50 to 100 milliseconds after, you're going to get some feed forward activation to create core stability, right? Eye stability, core stability, shoulder stability, elbow stability, wrist stability, finger motion, right? That's our stability patterns. And this is where it comes down when you start looking at vestibular nuclei, red nuclei, reticular system. These are the stability patterns. And so how it works is you have what's called an efferent copy. And your efferent copy is the blueprint of the movement. And when you look at blueprints of the movement, the way your brain computes the blueprint of your movement is the blueprint is actually the predicted feedback. And so your brain's learned how to move, and it says, if I want to pick up, or for this example, if I want to rotate my head to the right, what that should mean is that I have a predicted feedback of how my body is going to send my brain information. And what happens is the efferent copy comes down to the spinal cord and the brainstem and the basal ganglia and the cerebellum and all these motor areas and gives the blueprint. And then it filters everything else that's normal, meaning that if I tell the brain to look right and my feedback estimation is exactly the same as the movement, my brain does not get any feedback from the muscles and joints. I'm going to say it again. If you plan a movement and the movement is accurate, there's very little feedback that gets to your cerebral cortex. What your brain gets is a hit of dopamine. And that hit of dopamine reinforces the movement. So all these theories about paper clips is freaking moronic because most of your feedback is inhibited by your brain, right? People have spinal cord issues in their neck and they've got IQs better than most of us, right? Muscle joint integrity, muscle integrity is important. This theory that's necessity for life is not true. It's really important, right? But the fact is, most of our feedback in our body is gated before it ever reaches the cerebral cortex. The only thing that reaches the cerebral cortex is the error messages so that your brain can compute the errors and then it could feed back into the basal ganglia and the cerebellum to fix the motor program so you could do it better the next time, right? And so when you look at passive versus active motion, what you're really looking at is you're looking at integrity of the feedback system. And you're saying, when I create this feedback, so when you rotated his head to the right and it got stronger, that's indicative of possibly a cervical spine. We'll call it a subluxation, right? Because you guys are at Life University and you guys are allowed to use that word. And so we'll call it a subluxation. And you want to look at that, right? It doesn't mean that you have to treat it, but it's something to look at. And you could, or I'll say differently, it doesn't mean you have to adjust it because you could treat it different ways. But at the end of the day, you might adjust it. I like adjusting, and so adjusting is great. And now, but when he turns his head actively, it gets stronger. And so what that's telling you is you need to create more active rehab exercises for him. Like sitting there and just passively moving his head on dots is not going to be the best thing for him. He's better doing more active exercises and trying to recreate and repattern different movements. And so for him, doing active VOR exercises, I promise you will fix that weak muscle. Adjusting it might temporarily fix it, but he has a motor, most likely, right? And I don't know him or her or whoever it is, but most likely he's got a motor control issue over the neck. And what you want to do is get better motor control over the neck. And if you've got a motor control over the neck issue, chances are you've got motor control over the spine. And if you've got motor control issues on the spine, chances are you got motor control over your proximal joint issues. And if you got proximal joint issues, it's going to go distal, right? And so when you look at eye head control, it's almost like, in my perspective, if I see eye head issues, I'm not doing anything else because everything else is secondary a lot of times. Because when you look at your reference frames of your brain's in your head, and it needs to know where it is in space for it to compute the body. Or I always use the example of Heidi Horvath's research. You might have looked at Heidi's research. She has research looking at joint angulation of the elbow, and people with subclinical neck pain have a misinterpretation of the elbow. And then she looks for the subluxation, she adjusts, and some people hate her for that. She looks at subluxations in research. Other people love her for it, but it is what it is. And then you adjust the neck at the subluxation, and then it improved the elbow position sense. She didn't touch the elbow. What does that mean? It means you have no idea where your arm and leg is in space. What you know is where your arm and leg is in space relative to your trunk. You don't know where your low back is in your mid back. You know where it is relative to your neck. You know where your head is relative to your neck, right? And these are all reference points to figure out where things are. And if you don't know where your head is in space, you're not going to be able to fix a lot of things, or they're not going to last, because it's all going to fall back apart the second someone moves their head, which is all the time, right? And so what we want to do is and this is part of why chiropractic, and look, this is why you could literally focus on one bone in the body and help a lot of people, right? It's ridiculous, but it works, right? And so the fact is, because how do you know where your head is in space? Your inner ear, your vision, and your body, specifically your upper cervical spine, right? And you look at NUCA or AO or these techniques that look ridiculous, but they're effective and they work because they're creating stimulation to the neck in a very specific pattern, in a very specific vector that's very brain friendly, and it's reorganizing spatial orientation over the head and neck. There's a lot of research in eye movements that your eyes won't do so well if you've got instability in your neck, right? And so neck stability is really important, and the upper neck is really important for stability. And so that type of scenario, we're going to say we need to do more active exercises to recreate better motor control over his neck. Other things I like to do is let's bring that person back up and let's try a few other things with him. Right, so we know active rotation made it better. So let's play with that a little bit. So is the muscle still weak? Check that left hip flexor. Sweet. Now let's have him look straight ahead at a target, and he's going to do like a ×1 VOR. So he's going to turn his head left while looking straight ahead, and you're going to recheck it while he looks straight ahead. And now turn his head right while he looks straight ahead. He turns his head right looking straight ahead, and then you're going to recheck it. Any difference? Stronger with ×1 to the right, it looked like, or both ways? To the right, cool. Now let's do a ×2. So now what you're going to do is his head's going to go left and your finger goes right a little bit. And then his head goes right and your finger goes left a little bit, and you're going to test it. Yeah, you're going to see it's a little confusing for people. They got to do it themselves. Good, now try the other one. And keep looking at that thumb while you do it. There you go. So weak on both of those, it look like? Cool. And now let's do a ×0 where you're following eyes and head in the same direction, and you'll check it. Yep, so follow with your eyes and nose. Yep, just like that. And then check. And then follow eyes and nose. And check. Both weak. Cool. So what you get right now is you're finding with an active head rotation with no fixation point, it's pretty cool, right? And so what does that mean? That means like reaction time training. I'm going to want to do a lot of reaction time training him. moving his eyes or his head to the right, right? As far as that's that passive activity. If we don't fix it that way, when we look at active activity, it's bilateral. So we can move his head left and right with reaction time pretty well, and he's pretty good. But the second he focuses on a target and moves his head, it's different. Everyone sees that it's different. You wouldn't think it would be, but it definitely is different. There are different pathways. And so we see times one, he's better to the right. Times two is not so good. And his active head turn. So let's just do a few times one to the rights. So what we're going to do is we're going to have him. Actually, you know what we can do? Let's do one more thing. What you're going to do is you're going to take his head. And I don't know if you've ever done this before. So this is, honestly, I do a lot of this in my clinic. It looks ridiculous. It helps a lot of people. And so what you're going to do is stand in front of him and put your hands on his head, arms straight, and he's going to have him look at your nose. And I want you to do is passively times 0. So you're going to move your head to his right, and you're going to move his head right with you. So you're going to keep moving him and then back to center. And you're going to do 3 of those. So you're going to just keep moving, right? So it's a passive times 0. So you're just going to go in the same direction. Yeah, so try going the same direction. So just go to the right 3 times. So 1, go to the right again. 2, and go to the right again. 3, and then recheck the hip flexor. Strong or weak? Strongish. Now go to the left 3 times and check it. And check it. Stronger, weaker-ish, better. So let's do this. Ready? This is what you're going to do. You're going to take his head. You're going to do 2 times passive via, and you see before I go, it's different passive versus active. Everyone sees that? I treat a lot of chronic pain patients with passive VOR times 0s. I would have told you differently a few years ago. I taught the vestibular program, and some of you might have taken my vestibular program. Unfortunately, the first thing I do with people is like positional maneuvers, and that's what people kind of know me for sometimes. It's like the least thing I do in my clinic. You know, to be honest with you, it's like if everything I do, that's like 2% of what I do every day. But every time you throw a new patient at me, it's the first thing I'm going to do. And so every time in the seminars I get a new patient, it looks like that's all I do. It's very little of what I do. I do a lot more of what I'm about to show you versus reposition maneuvers, but I love reposition maneuvers. They're great initial treatments, but I don't do them that much. So let's go again, and let's do 2 times passive to the left, and then 2 times 1 to the right. Just focusing on your nose. So 1 and 2, and then you're gonna go center, and then just move his head now. You stay still to the right. So now passive down. Yep, 1. Good, just like that. And 2. And do it again. We're gonna do 3 sets. That's 1 set. So do it 2 more times. No, just do it 2 more times. So 1, and speed it up a little bit. You don't have to go as far. So shorter and faster. That's cool. And then yeah, 1 a little shorter and faster. So yeah, that's cool right there. Do 1 more time. Check the muscle. Weak. Sweet. Now what you're going to do is do the times 0 to the right. Yep, do it again. 2 times, another 2. Recheck the muscle. Now what you do is do the times 1 again. So just do 2 times 1. Okay, and go a little lower. So you're a little high on him. So go a little lower. So bring your nose a little lower. So he's looking a little more eye level if you can. Right, because all these details matter, right? Yep, there you go. So you want to really be eye level, and do 2 more of those. And do 2 more. And check it. Nothing? Cool. Now passively turn his head to the right. Check it. No, just passively hold it there. So just like the test for, so passively turn it, hold it there and check it. Nothing? Because before passively to the right made it strong, correct? Not so much anymore, right? So is it weak right now? Strong, man. So let's talk about this for a second, right? If someone has poor motor control of their neck and you just start doing motor control exercises and active exercises, it might not be the best thing for them. Everyone sees that? And so even though you challenge and it look good, if you try to translate the therapy, this is where muscle testing can help, because just because it challenges, you then do it in a therapy. And if it goes weak, it's too much. The fact he challenged, and that's why I made a point of that. The fact that he challenged well on that active exercise and not passive already shows that he's got an issue with his motor control of his neck. And it typically means that, from my perspective, and this is how I look at things, I tried to cheat the system, and you can see muscle testing doesn't lie, right? And because what you can see is that if you have poor active control over your neck, it typically means you have poor perception of where your head is in space. And if you don't know where your head is in space, you can't move it from point A to point B. And if you're just going to start doing exercises and rehab for somebody because you learned it at a seminar or because it muscle tested or because it made sense, and you're not checking your objective measurements, what can happen is you could really mess somebody up, right? If all of a sudden I said it's get strong, the muscle's strong, do tons of VOR exercises, he's not going to feel better. If anything, he could feel worse because his motor control over his neck is wrong. The first thing we do is what's the perception and what's the body map of his head and neck? What I do is I understand physiologically the oldest system that gives you a perception of the head and neck is the vestibular system. 400 million years ago, there were jellyfish with an otolithic system that told them tilt and translation. 100 million years ago, there were fish that developed canals and developed spinal muscles and reflexively allowed us to have reflexive spinal muscle activity from our inner ear. Later on, we got eyeballs and vision and limbs, but it all feeds into our vestibular system, which is the most basic system that tells us where our whole body is in space, let alone where our head is in space, right? Because the inner ear is all about head in space. And so from my perspective, what I do, this is when I do repositional maneuvers. So why don't we check real quick? So lift up, so go back, let's keep them right there. Or it doesn't matter, you can rotate them, whatever you want, but check that hip flexor. And I'll show you what I do mostly in my clinic when it comes to muscle testing. It's strong now? Cool, there we go. I see a little weak. Now I want you to do is left head tilt. So tilt this head to the left and check it again. Right head tilt. Good, both weak. Now what you're gonna do is rotate his head to the right and bring his head back into extension. So rotate and extend it. So bring it back into extension. So it's like a right posterior canal position. Now check it. Good. And now bring it to the left and bring it back. So left posterior canal and check it. Yep. And check it. Cool. Now bring it forward. So go into flexion. Left rotation and deflection. Flexion. Like right anterior canal. Check it. And then right rotation and flexion. Left anterior canal. Any change or all weak? Posterior canal better, right? So right posterior canal better, right anterior canal good, right? So right posterior, right anterior, those are the two that made it better. And so now take a strong muscle. So pick a strong muscle, doesn't matter which one, just grab a strong muscle and test it. And now you're gonna go to those opposite canals. So now you're gonna go to the left anterior canal because that is what's opposite of the right posterior. And you're gonna check a strong muscle. And you're gonna say, does the strong muscle go weak or does it stay strong? And that stays pretty strong, it looks like. And now what we're gonna do is you're gonna go to left posterior, right? The right anterior is good, so go left posterior canal. So, yep, and then check the strong muscle. And that's pretty good. Still strong, sweet. So now go back to the weak muscle. Check the weak muscle. do some right figure eights of the arm. Do like 5 figure eights of the arm. Yeah, and recheck. Tell me if that made any difference. Not so much. Not so much. Cool. So it made it worse, right? So do left side. So try left side complex movements. Again, this is not how I treat people every day, but when you look at muscle testing, this is part of the game. Again, recheck it. Nothing. So what can we tell neurologically about this patient? Right off the bat, we know there's a motor control issue. When you look at the motor control, what area is very big on motor control? Your cerebellum. When you look at your cerebellum and these complex movements, it blows them out right away. Everyone sees that? It'd be really cool if I could come in here and just turn every muscle on remotely from an online Zoom call. But the fact is, I have no influence over this, right? You picked a muscle that may or may not relate to its chief complaint. And the fact is, you get your data that you get. And so to me, all this is important data. Where the last patient, we looked at the brainstem. To me, this screams cerebellum. And I'd be curious to look at his dysdiadokinesia. I'd be curious to look at his finger to nose. I'd be curious to look at his posture responses. I'd be curious to look at his autonomics, and so you look at midline, so I'd be curious to look at all this stuff, and it may or may not show up, but that's what I'd be really curious about. You could do rebound testing and I'd look at certain cerebellar aspects and say, right, I don't need to do a full neurological exam. If I understand the physiology of my muscle testing, I could then take a couple objective measurements and I could test it. Like, honestly, you could take this patient and just adjust his neck, and that alone might fix a lot. But if you don't have an objective measurement to prove that, you're not going to see it. So what I would do is I would adjust his, like at the most basic level, I'd adjust his neck, not knowing any of his visual testing, right? Because the visual testing might be, eyes open, eyes closed, might be a big picture. But not knowing any of that, I would adjust his neck and I'd re-challenge all these active movements and see by a peripheral adjustment, did you feed into the brain and improve motor control? And if you did, then I'd start giving some active movements to strengthen it. But right now, can we all agree that no matter what we did, it seemed to make it worse, right? And the things that made it better didn't really correlate with kind of what we were wanted. And so I wouldn't do any of that stuff, right? I wouldn't do any of it, like, because it's going to make him worse. And what I would do is I'd really understand, like for me in my clinic, I do tons of cranial work, right? Tons of cranial work. And cranial work I love because it's all head positioned. And so for me, motor control of the head and neck, I'm coming in and I'm looking at his palate, I'm looking at his jaw, I'm looking at his cranium, I'm looking at his eye movements, I'm looking at his posture, I'm looking at his autonomics, and I'm looking at all this to figure out, why is this system so unstable, right? Like, why do all these things blow out this muscle? Because at the very least, some complex movements shouldn't do anything. We all agree. A couple of figure eights really shouldn't do anything. Shouldn't really make it strong or weak unless there's something significant. And if you get weak on both the right complex movements and left complex movements, as I told you, if you don't know where your neck is, you don't know where your limbs are. And if you adjust his extremities right now, it's probably not going to be, it's probably either going to come back or it's not going to be as beneficial as it could be until he knows where his neck is. Right. And that might be a NUCA, that might be adjusting, that might be adjusting his talus, who knows, but I start cranial work, I start jaw, I start palate, I start vestibular. And then from there, I go down to the neck. And from there, I go down to the trunk. And then from there, I go down to the limbs. Right. And so that's my progress usually for people. It's top down, trying to remap their whole body to fix their problem. Any questions before we finish off? I know it's a lot. It's really hard to do clinical apps on Zoom. And so I really hope it was something worth it. I know it's late at night. So I hope it was something. I'm happy at some point to come up and talk to you guys or in person, because it's much better to have it active. All I can tell you to do is, number one, if you'd like to do the case reviews and actually go through looking at the VNGs, looking at the Vertex, looking at the QEGs, looking at the exam, and walking through treatment protocols and showing you pre's and posts of people that I've seen in the last 9 months in this clinic. I'm happy to kind of do that online with you guys, and we could record Zooms and put it on websites or put it on Facebook or whatever. Happy to do that. In all honesty, to finish up, like I was a student not that long ago. I graduated in 2014. I had a unique opportunity to watch Dr. Carrick personally, and I spent years around him, and it kind of, changed the way I treat. And it was very beneficial. And so that's why I do this stuff is, to try, I understand the position you guys are in, and I understand the pros and cons of it. And if there's any way, you look at the people that are around him, you had me, we had a lot of people, right? Dr. Ellis is all over the place. You had a lot of Esposito was there. But definitely like me, Dr. Kaiser, Dr. Antonucci, Dr. Hubbard, Dr. Libba, Jerome, there's certain people that are definitely there a lot. And not that we're better or worse, but we have a little more influence of what Carrick does back then, at least. And so that's why all I can tell you over and over and over and over and over again, as a student, stay out of the politics, stay out of the BS. Don't get too into your head of what your belief systems are, and just go and see other doctors treat, right? And go and see it. Go to as many clinicians as you can, clinics as you can, and see what people are doing, see what works, see what doesn't, see what you like, see what you don't like, and try to be as open-minded as you can, because psychology, and I'll finish on this, psychology dictates whether your patients get better or whether you get patients better, because your patient's psychology is going to pick whether they choose you as a doctor or somebody else based on their belief systems, based on if you're nice, based on what you look like, based on your website. And you as a doctor, you're going to pick techniques that resonate with you, but it doesn't mean that you're correct. Nowhere in your brain there's a truth meter, right? And so the more closed-minded you are, the less opportunity that you'll be able to help people, because you'll be limited in your ability to help, because you'll be so specialized, because there's so many things that can help people. The more open-minded you are, the better you'll be. You don't have to do everything, but to make better referrals, right? It might not be, you might love emotional work. You might be doing NET all day. And I love AK, by the way. I love muscle testing. I don't mean anything negative when I talk about it. It's just a bad indicator for objective measurements, right? And but NET is great. And you might be an NET person, do great emotional work. We have their whole homeopathy line here. Like, I love NET. And you might not want to do any neuro. And that's amazing. But some people might need neuro and you might need a referral, and vice versa. I refer many of my patients to a physical therapist in Denver that does something called the cellular release technique from a hypnotist. And it's an emotional clearing technique that I'll put hand in hand against anything out there. I'm trained in NET, I'm trained in EFT, I'm trained in done EMDR, new Germanic medicine. You know what I mean? Like there's a few techniques that are up there that are amazing. And this is one of them, and it's really, so I love emotional techniques. I refer for that, and it's not what I do, but I make sure people get it. So long story short, keep studying, keep learning, see as many doctors as you can, and feel free to contact me if there's anything I can do to help you guys. So thank you very much.